So just a few words about emerging antidotes. So again, Andexanet Alfa is the very specific antidote for the 10A inhibitors. It's a modified factor 10A, which works essentially as a decoy. It binds to and removes the 10A inhibitor from the circulation with very high affinity. In clinical trials that have been done so far, it's been administered to a substantial number of healthy volunteers and some patients who are actively bleeding. It's had really no significant adverse effects. We haven't seen any evidence of thrombosis, although when it's administered to patients with no anti-10A inhibitor on board, there is some evidence of activation of coagulation, which may be beneficial in an actively bleeding patient. It produces short-term reversal after an intravenous bolus, and you can administer an infusion to produce long-term reversal. And there's trials going on now, a large clinical trial, which is enrolling patients treated with rivaroxaban and apixaban, and we anticipate shortly being able to add other 10A inhibitors to the eligible medications. Andexanet Alfa produces reliable reversal of the anti-factor 10A effect of all of the 10A inhibitors, and this has been shown in numerous publications at conferences over the last 2 or 3 years. Essentially, to summarize all of the results, when you give an appropriate dose of Andexanet Alfa, you produce a proportionate reduction in the levels of anti-factor 10A of any of the agents. The effect is immediate at the end of the infusion and lasts for a period of about an hour or so. The drug has a short half-life, and then the drug returns to its anticipated level. You can prevent this recrudescence of the anti-10A effect by giving an infusion at the time of the bolus. And you can see from this slide that, for example, with rivaroxaban, there's a dose-dependent reduction in the 10A inhibition as you increase the dose of the Andexanet Alfa. There's a large clinical development program, and the first of the studies that is probably going to lead to licensure of this product is called ANNEXA. It's divided into 2 parts. Part 1 is a bolus infusion of rivaroxaban. The primary endpoint is a surrogate, the percent change in anti-factor 10A activity from baseline to nadir in patients who are dosed to steady state and then receive a dose of the Andexanet Alfa. The secondary endpoints are the occurrence of an 80% or greater reduction in anti-factor 10A levels, the change in free rivaroxaban concentrations, changes in thrombin generation, and the occurrence of thrombin generation above the lower limit of the derived normal range. So in this slide, again, we see that when Andexanet Alfa is administered to patients who've been dosed to steady state with rivaroxaban, we get excellent reversal of the anti-factor 10A effect of the rivaroxaban. And as a note, in previous phase 2 and phase 1 studies, we've seen identical results with apixaban and with other 10A inhibitors. In this study, we demonstrate the part 1 of the ANNEXA study that we met our primary endpoint of a reduction in the anti-factor 10A level. In this slide, interestingly enough, we would have had 100% reversal, except one patient probably didn't receive any Andexanet because of a malfunction of their IV. The secondary endpoint was having more than 80% reduction in the anti-factor 10A level, and there were highly statistically significant differences between the placebo and the Andexanet group. And this, again, is very consistent with results in the many previous publications, abstracts that we have in this area. There were a number of other endpoints in this study, all of which were also successful. So, for example, we identified a dramatic and predictable reduction in free rivaroxaban, and in addition, we demonstrated that thrombin generation returned rapidly into the reference interval and much more quickly with the administration of Andexanet Alfa than was seen with the administration of placebo. So there's no doubt that with the new anticoagulant agents, we've really entered a new era in anticoagulant therapy. Much greater choice, probably easier to use than warfarin, probably safer than warfarin in many patients. Problem, of course, is that we don't have a reversal agent. It's been identified that there's a need for a reversal agent. We look forward to having reversal agents available to us, reversal agents that are able to ameliorate bleeding complications in really sick patients taking these anticoagulants. There's a lot of active research in this domain, publications almost every month, certainly every major scientific congress. An exciting area to be working in. We look forward to additional information.